Hi everyone, a blessed day to all. Praying that all of you are safe and doing well together with your families and loved ones. So, how's everyone? So, I hope you were able to recharge yourself, your mind, body, and spirit during the Holy Week. So, at least you were able to give yourself a reward to breath out all the stress that you have been dealing with. Before proceeding for our topic this week, let me present to you these disclaimer slides. Alright, so this week our topic is about the physical examination of the gastrointestinal and renal systems. So this is the very first topic for this week. And there's one more topic about the physical examination of reproductive system. So again, this first topic is divided into two parts. Okay, so this is the first part of the gastrointestinal and renal system. So these are the learning objectives of this presentation. First, at the end of this presentation, the student will be able to identify the structures and function of the gastrointestinal and renal systems, collect and accurate health history of the gastrointestinal and renal system, describe the physical examination techniques and the order performed to evaluate the gastrointestinal and renal system. Perform a complete gastrointestinal and renal system examination. And then, of course, at the end, to be able to document a complete gastrointestinal and renal system based on the gathered data. So let us begin our topic with a review of your anatomy and physiology. So look at this image. So this is the gastrointestinal system. Okay. The gastrointestinal system and the renal system encompasses many organs of the body. So as a student, it is important for you to be familiar with the site and the function of each organ, okay? And in which quadrant of the abdomen each of these organs is located for your assessment. So, your landmark of the abdominal wall and the pelvis are illustrated in this picture. Okay. So, the rectus abdominis muscle became more prominent when the patient raises the head and the shoulders from the supine position. Okay, so those are the parts of the abdomen. Okay, the outer part of the abdomen. Okay, so for descriptive purposes, so we have to divide the abdomen using the imaginary lines, okay, crossing at the umbilicus, forming the right upper quadrant, okay, the right lower quadrant, the left upper quadrant, and the lower or the left lower quadrant. Okay, so moving on to the internal abdominal organs. Okay, to examine the abdomen, we have to move in a clockwise rotation. Okay, so several organs are often palpable, of course, except the stomach and some parts of the liver and spleen. Okay, so the internal organs lies high in the abdominal cavity that are close to the diaphragm, where they are protected by the thoracic ribs beyond the reach of the palpating hands. Okay, the dome of the diaphragm lies approximately the fifth anterior intercostal space. Okay. So in the right upper quadrant, the soft consistency of the liver makes it difficult to palpate through the abdominal wall. However, the lower margin of the liver edge, it is often palpable at the right costal margins. The gallbladder, which is located here, it rests against the inferior surface of the liver, and it is more deeply lying duodenum are generally, of course, not palpable. Okay, so moving medially, okay, as an examiner, you can encounter the rib cage with its xiphoid process. This xiphoid process protects the stomach and the spleen. Okay, so the abdominal aorta are often visible or has visible pulsations and is usually palpable in the upper abdomen. Okay, I remember when I was in the province, no, kapag sumasakit yung tiyan or sinisikmura, nakakapa itong parang pulsations na to. And tinatawag ito sa province namin na kabuhi or gikabuhi. And then they're going to massage it, or the hilot will touch this one, which is actually wrong pala. Nalaman ko lang ito when I studied nursing, na mali pala yung hihilutin natin yung pulsations na yon, because baka magkaroon pa ng aneurysm. Okay? So at the deeper level, the lower pole of the right kidney may be felt, no, here, especially in the children or in a thin person, okay, with a relaxed abdominal muscles. In the left upper quadrant, okay, so the spleen is lateral and behind the stomach, so it's just above the left kidney in the left mid-axillary line. Okay, so its upper margin, okay, rests against the dome of the diaphragm. Okay, so moving on to the organs by quadrant. So on the right upper quadrant, you have the ascending colon, the duodenum, the gallbladder, the right kidney, liver, and the head of the pancreas, the transverse colon, and the right ureter. On the right lower quadrant, you have the appendix, the ascending colon, the bladder, the cecum, the rectum, the ovary, uterus, the fallopian tube for female. For male, you have prostate and the spermatocord, the small intestine, and the right ureter. On the left upper quadrant, you have the descending colon, the left kidney, the body and the tail of the pancreas, the spleen, the stomach, the transverse colon, the ureter, or the left ureter. And on the left lower quadrant, you have the bladder, the descending colon, the ovary, the uterus, the fallopian tube for a female, prostate and spermatocord for male, and the small intestine, sigmoid colon, and the left ureter. So why it is important for you to know the organs by quadrant? Okay, this is because this is very important during your assessment. Okay, for example, your patient comes to your clinic or into the hospital or in the emergency room complaining of abdominal pain. So, napakalaki ng parts and there are so many organs in the abdomen. So, it is important for you to be familiar. Actually, in other books, they divide the quadrant into 9 regions, not only 4. Okay, but here we will just focus the 4 quadrant. Okay, kasi for example, sasabihin ni patient or you will ask your patient, di ba, by using the old card, okay, you can ask your patient the onset of the pain and then you will ask your client the location of the pain. Okay, kapag tinuro ni client that the pain is located or nag-i-start yung pain at the right lower quadrant, now you will suspect ano kaya ang possible organs that are affected kasi sa right lower quadrant. Okay, so ang common affected, lalo na kapag may sakit ng right lower quadrant, diba, iniisip agad natin, baka appendicitis or there is an inflammation of the appendix. That is just an example. Okay? Not only the appendix, because again, there are many organs that are located in your right lower quadrant. Okay, moving on to our anatomy of the renal system or the posterior organs. Okay, so the kidneys are retroperitoneal or what we call as posterior organs. So the ribs protect their actually upper portions. Okay, the costovertebral angle is formed by the lower border of the 12th rib and the transverse process of the upper lumbar vertebrae. So this defines the region to assess for kidney tenderness or pain, also called as costovertebral angle tenderness or CVAT. Okay. Okay, so just a questions or icebreaker. Okay, so can you please try to recall what you've learned? So the left lower quadrant contains all the following structures except A, urinary bladder, B, sigmoid colon, C, spleen, D, descending colon. So what's your answer? Okay, I'll give you 10 seconds. Alright, so this is the answer to question number 1. Okay, the left lower quadrant contains all of the following structure except the spleen. Of course, your spleen is located in the left upper quadrant. So, the left lower quadrant contains the bladder, descending colon, small intestine, the sigmoid colon, the ureter and ovary, uterus, fallopian tube, or prostate and the spermaticary. Okay, so let us now proceed to the health history. Okay, so for gastrointestinal system, it is important to check or to assess for the abdominal pain, acute and chronic pain. If there is indigestion, nausea, vomiting, including hematemesis or blood in the vomitus. Is there loss of appetite or early satiety? In Tagalog, madaling mabusog. Okay? Is there dysphagia or difficulty swallowing? And or odinophagia or a painful swallowing? Is there change in bowel function, diarrhea, constipation, or jaundice? So these are all included in your gastrointestinal health history taking. For the urinary and the renal system, okay, the health history should include the following. the suprapubic pain, okay, dysuria or difficulty urinating, urgency or frequency, ihi ng ihi, hesitancy, decreased stream in meals, konting ihi lang, okay, polyuria or nocturia, okay, urinary incontinence, hematuria or blood in the urine, there is flank pain, and ureteral colic. Each of these we will discuss in the next slides. Okay, so before exploring the gastrointestinal and genitourinary symptoms, it is important for us to review the mechanism and the clinical patterns of abdominal pain. It's important for you as a nursing student to be familiar with the three broad categories of abdominal pain. First, we have the visceral pain, which may be difficult to localize. Okay, parang hindi mo alam kung saan talaga siya nagsisimula. It is typically palpable near the midline. So it varies in quality. It may be groaning, burning, cramping, or aching. So when it is severe, it is maybe associated with sweating, so pinagpapawisan, no? Pallor, nausea, vomiting, and restlessness. Okay, that's visceral pain. Okay, so the visceral pain occurs when the hollow abdominal organs such as the intestine or the biliary tree contract unusually, forcefully, or are distended, or it is stretched. Okay, so solid organs such as the liver can also become painful when there is or when the capsule are stretched. Okay, so again, visceral pain may be difficult to localize. For example, there is a visceral periumbilical pain. This could suggest an early acute appendicitis, no? Kapag merong ganong visceral of nag-start sa periumbilical pain. So hindi lang pala right, no? Baka isipin nyo dito lang sa right. So possible na merong periumbilical pain siya. Okay? This is due to from the tension of the inflamed appendix that it gradually changes to parietal pain in the right lower quadrant. Okay, that is due to inflammation of the adjacent parietal peritoneum. So again, usually nag-i-start siya here, no? Yan. So kapag merong epigastric pain, this can be from the stomach or the duodenum or pancreas. Okay, so merong mga description kung ano yung parts or organs that are affected. So another type of pain or problems or patterns and mechanisms of abdominal pain, the second one is what we call the parietal pain that originates from inflammation of the parietal peritoneum or what we call or known as peritonitis. It is steady, aching pain that is usually more severe than visceral pain. Okay, it is more precisely localized. It is aggravated by movement or coughing, so mas sumasakit siya, and the patients prefer to lie still. Mas gusto niyang nakahiga lang. Okay, so the third type or the third problems and mechanisms of abdominal pain is referred pain, which is felt in more distant sites, which are innervated at approximately the same spinal level as the inflamed structures. Okay, it develops as initial pain that becomes more intense. It seems to radiate or travel from original site. That's why we refer to other region of the body. It may start in other region and refer to the abdomen. Okay, so let's continue with the health history of the gastrointestinal tract. Okay, so acute upper abdominal pain or discomfort. Okay, so you have to use your old card in assessing your client. Okay, so for patient with abdominal pain, sometimes the causes ranges from benign to life-threatening. So make sure to take time to conduct a careful history, and you have to ask the patient to describe the pain in their own words, and you can use your old card. Okay. So for example, so old card, you can ask or you can ask your patient, or you have to determine if it is acute or chronic pain. So remember that acute abdominal pain has many patterns. Okay, so you have to ask your patient, did the pain start suddenly or gradually? When did it begin? So example lang of the onset and then so on. For the chronic upper abdominal discomfort or pain, okay, so you have to assess if it is due to dyspepsia, discomfort that may be non-painful but just uncomfortable, or is there a feeling of heartburn, or it is atypical respiratory symptoms. So is it alarming symptoms? Yeah. Okay, for the lower abdominal pain and discomfort, you have to take note that acute lower abdominal pain, particularly in the right lower quadrant, you have to assess if it is sharp and continuous, tuloy-tuloy. Is it intermittent and cramping? Is it rebound or doubled over? And then for the left lower quadrant or diffuse abdominal pain, you have to check if there is fever, okay, loss of appetite, is there absent of bowel sounds, firmness, or guarding ba talaga siya, and rebound tenderness. Of course, you know that what are the organs located in your left lower quadrant. Yung kidneys, ano pa yung affected. Okay, so for the chronic lower abdominal pain, you have to check if there is change in bowel habits, alternating diarrhea and constipation. Is there change in the form of stool? Okay, and intermittent pain with relief from defecation, and then you can check the possible causes of this pain on your book, on table 16.1. Okay, the following are the gastrointestinal symptoms that are associated with abdominal pain. Okay, there, you can check if there is nausea. Okay, so what do you mean by nausea? This is often described as feeling sick in my stomach. Okay, may progress to retching and vomiting. So, ano ba ang retching? So, retching is described as involuntary spasm of the stomach, the diaphragm, and esophagus that precedes and culminates in vomiting. Okay, so the forceful expulsion of gastric contents out of the mouth. And regurgitation usually occurs in those patients suffering with GERD or gastroesophageal reflux disease. Okay, or those who have esophageal stricture and esophageal cancer or gastric contents without nausea or retching. This is called regurgitation. Okay, you have to ask about the vomitus, okay, or regurgitated materials, and you have to inspect it if possible to note for the color, the odor, the quantity, okay. Assess the patient with the amount, no? Gaano ba kadami yung vomitus? Is it ilang ml kaya, or ilang kutsara, ilang teaspoon, tablespoon, or cup? Yan. Anorexia. Okay. Another one is, again, you have to check kung may loss of appetite. Okay? Or lack of appetite. So, you have to check kung ano ba yung cause ng anorexia. You have to find out if it arises from intolerance of certain foods, distortion of self-image, okay, kaya nawawalan ng gana, abdominal discomfort, which is real or perceived, or a fear of food. Okay, you have to check for any associated symptom of nausea. So these are other gastrointestinal symptoms. We have dysphagia, or difficulty swallowing, or your odinophagia, or painful swallowing. Okay, a change in bowel habits, diarrhea, constipation, jaundice, and the color of the stools. Also, all of the symptoms and their possible causes can be found in your book. Okay, moving on to the health history of the renal system. So these are the general questions, okay, that you will ask your patient. Okay, is there a difficulty passing urine? How often do you go to the comfort room? Okay, do you get up at night? How often? Okay, how much urine do you pass? Is there pain or burning during urination? Ever leak urine? Wet self involuntarily, or trouble getting to restroom in time? Hindi pa nakakarating sa CR, naiihina, or napapaihina sa panty, di ba? And then you have to know when the bladder is full. Okay. So, involuntary voiding or lack of awareness suggests cognitive, or baka may problem with the neurosensory deficits. Okay, moving forward now. You have to check for the health history of the renal system. Is there suprapubic pain? Okay, disorders in the urinary tract may cause pain in either the abdomen or the back. So, bladder disorders may cause, again, suprapubic pain. So, in bladder infection, the pain in the lower abdomen is typically dull and pressure-like. Okay. However, in sudden overdistension of the bladder, pain is often agonizing. In contrast, chronic bladder distension is usually painless. Okay. So check for dysuria, urgency, frequency, polyuria, nocturia. Okay. When there is urgency, okay, it suggests urinary tract infection, or there is an irritation from possible urinary calculi. However, frequency is common in urinary tract infection, yung may mga UTI, ihi ng ihi, and bladder neck obstruction. So in men, painful urination or dysuria without frequency or urgency could suggest urethritis, or inflammation of the ureter. Okay. Okay, polyuria. Ano ba ibig sabihin ng polyuria? This refers to a significant increase in 24-hour urine volume, roughly defined as more than 3 liters of urine within 24 hours. Okay? So, ilan lang ba ang normal Diba dapat 30 cc per hour lang. Okay, so that's about 1,500 to 2,000 a day. So more than 3 liters or ml yun, no? 1,500 ml or 1.5 liters to 2 liters. So, kapag more than 3 na siya, polyuria na siya. Okay? So, you have to distinguish polyuria between frequency kasi pwedeng ihi ng ihi pero konti lang naman yung iniihi. Yung polyuria, marami ang kanyang urine output. Okay? Or there is high volume of urine output. So, what is nocturia? This refers to urinary frequency at night, no, na nagigising ka para umihi. Okay? Not only once in the night, but more than once. The volume could be large or could be small. So, you have to check if there is urinary incontinence. Okay? Probably there's an involuntary loss of urine that can be socially limiting or can cause problems with the hygiene kasi naiihi ka na lang basta-basta. Okay? Hematuria, or there is blood in the urine. Okay? Or it is important for you to take note, no? Dapat this is important cause for concern. So, when the blood is visible to the naked eye, it is called gross hematuria. But when the urine may appear or may be detected only during microscopic urinalysis, this is known microscopic hematuria. Okay, check for kidney or flank pain. Okay, so kidney pain is actually reported as flank pain, or it is below the posterior costal margin near the costovertebral angle. So it may radiate anteriorly towards the umbilicus. So the kidney pain is known as a visceral pain that is usually produced by the extension of the renal capsule, and that is typically dull, aching, and steady. Okay, check for urethral colic. It is a dramatically different, severe colicky pain originating at the costovertebral angle, and it is radiating around the trunk into the lower quadrant of the abdomen and the groin, or possibly into the right or into the upper thigh, okay, testicle or labium. Okay, so let's have an icebreaker again. So let's check this question. Which of the following complaints indicates the patient may have cholecystitis? Okay, or inflammation of the gallbladder. Okay, so is it, you have to choose all that apply, right? Upper quadrant pain, nausea, vomiting, and fever. Okay. I'll give you 10 minutes. Alright, so let's check if your answer is correct. Okay, so this is the answer to question number 2, or the question in the previous slides. Which of the following complaints indicate the patient may have cholecystitis? You have to choose all that applies. So gallbladder, no? Your gallbladder, so the correct answer are the following, no? The right upper quadrant, the nausea, and the vomiting. You have to remember that the patient may not have a fever. The other symptoms, as well as the positive Murphy sign, are possible indicators of acute cholecystitis or inflammation of the gallbladder. Okay, so let's now proceed to the physical examination. Okay, make sure that you have the following. You have your equipment, you have your good lighting, you have your stethoscope, the tape measure with centimeter markings, And then the patient should be placed in relaxed, well draped, and then of course you ask the client to void first before proceeding with the physical examination to avoid discomfort. And then you have to expose abdomen from xiphoid process to symphysis pubis. Okay, the groin must be visible and the genitals must be draped. So of course, that is to provide privacy to your patient. Okay, so moving on with our physical examination, those are the tips for enhancing the examination that you need to remember. Make sure to place your patient in a comfortable supine position with pillow under the head and perhaps the knee, or you can place your client in the low back flat on the table. Okay, patient's arm at side or folded across the chest and observe proper draping. Okay, expose only areas to be assessed. Examine areas of discomfort last, and we have to warm your hands and stethoscope. And then watch the patient's face for signs of discomfort, especially for those patients who are unable to talk or those patients that are unconscious. Okay. During the skin assessment, you have to take note of the following. Okay. Okay. In assessing or in doing the physical examination of the abdomen, we have to ito yung mga cardinal techniques. No? We have to start with inspection first. Okay, for the skin, you have to take note of the scars. Okay, you have to describe or diagram their location of the striae. When we say striae, that's an old silver striae or a stretch marks that are actually normal, especially kapag nanganak na or tumaba yung pasyente. The umbilicus, okay, the contour, the peristalsis, and the pulsations. Okay. Yun yung mga bagay na dapat natin i-observe. Okay, so those are the common findings, no? You have to check for the contour of the abdomen. If the abdomen is flat, is it rounded or protuberant or scaphoid? No, there is a markedly concave or hollowed. That can be maybe abnormal. Okay. Another, no, rounded abdomen. So you have to observe for bulging of the flanks of ascites and the suprapubic bulge or a distended bladder or pregnant uterus, or is there a femoral, umbilical, or inguinal hernia? So yun yung i-observe din natin. Okay. So another localized bulges in the abdominal wall, we have here umbilical hernia. So of course you have to inspect for abdominal symmetry, no? Is it symmetrical, diba? Asymmetry suggests a hernia or enlarged organ, or there could be mass. So you have to inspect for the lower abdominal mass of an ovarian or uterine tumor. Okay. And then we have here an example of umbilical hernia, where there is a protrusion through a defective umbilical ring that is most common in infants, but it can also occur in adults. So in infants, but not in adults, it will usually closes spontaneously within 1 to 2 years. But for adult, hindi na magko-close yan. So surgical procedure na yung gagawin. So we have here the incisional hernia. There is a protrusion through an operative scar. So, limbawa, ito ay ang scar na to. Siguro cesarean section yan, no? Na-move na siya dito. So, palpate to detect the length and the width of the defect in the abdominal wall. So a small defect through which a large hernia has passed has a greater risk for complications than a large defect. So you have to remember that, no? Pag mas maliit daw, mas maano yung defect. Okay? Sa ilalim kasi, yun, nagkaroon ng problem doon sa loob. So, another localized bulges in the abdominal wall, we have here the epigastric hernia. Yan. So, it is a small midline protrusion through a defect in the linea alba that occurs between the xiphoid process and the umbilicus. It's here. With the patient coughing or performing a Valsalva maneuver, you can palpate by running your finger pad down the linea alba to feel it. So another findings here, we have lipoma, which is common. Benign fatty tumors that is usually in the subcutaneous tissue. It can appear almost anywhere in the body, including the abdominal wall. There could be a small or large, and these are usually soft and often lobulated. You can press your finger down on the edge of the lipoma. So the tumor typically slips out from under your finger and it is well demarcated, non-reducible, and usually this is non-tender. Okay, so another localized bulges in the abdominal wall, we have the Diastasis Recti. So there is a separation of the two rectus abdominis muscles through which the abdominal contents from the midline ridge typically extends from the xiphoid to the umbilicus and seen only when the patient raises the head and the shoulders. So it is often present in patients with repeated pregnancies, obesity, and with chronic lung disease. It is clinically benign. So those are the protuberant abdomens. So fat, okay. Fat is the most common cause of protuberant abdomen. Fat thickens and the abdominal wall, the mesentery, and the omentum. So the umbilicus may appear sunken, nakalubog na. A panus or apron of fatty tissue may extend below the inguinal ligament and bumaba na. Lift it, look for inflammation in the skin folds or even for a hidden hernia. So it's important na buhatin mo yan. Iangat mo para makita natin if there is hidden hernia. So for the gas, or gaseous distension may be localized or generalized. It causes a tympanic percussion node. So selected folds may cause mild distension from increased intestinal gas production. Okay, this is more serious. Okay, if there are intestinal obstruction and adynamic or paralytic ileus. You have to note the location of the distension by looking at the quadrants of the abdomen, because the distension may becomes more marked in obstruction in the colon than in a small bowel. Okay. To continue with the protuberant abdomens, we have a tumor. Okay, a large solid tumor, usually rising out of the pelvis. It is dull to percuss. So it is air-filled bowel is displaced to the periphery. Okay, causes include ovarian tumor and uterine fibroids. Occasionally, a markedly distended bladder may be mistaken as a tumor kapag medyo distended yung bladder or baka punong-puno at hindi pa nakaihi. Or pregnancy is a common cause of a pelvic mass. So you have to listen for the fetal heart. Baka naman kala mo mass pero pregnant lang pala siya. Okay, so moving on to our protuberant abdomen. So we have ascitic fluid seeks the lowest point in the abdomen. Okay, producing bulging flank. Yeah, may bulging flank that are dull to percuss. The umbilicus may protrude, so you have to turn the patient onto one side to detect if there is the shift in position of the fluid level or shifting of the dullness. Okay, so to continue with our physical examination of the abdomen, after doing the inspection, we can now proceed to auscultation. Diba, unahin natin yung auscultation kasi kapag inuna natin yung percussion and palpation, it may alter. Okay, ma-alter yung bowel sounds. Okay, so for the abdomen, so if the patient has a high blood pressure, it is important to listen in the epigastrium and in each upper quadrant for bruits. So later in your examination, so when the patient sits up, you can also listen for the in the costovertebral angle. So note for epigastric bruits confined to systole may be heard normally. So a bruit in the midclavicular line that has both a systolic and diastolic components strongly suggests a renal artery stenosis as the cause of the hypertension. Okay, so bowel sounds. Okay, moving on to the sounds in the abdomen using your stethoscope. So increased as in diarrhea or early intestinal obstruction. So, increase yung bowel movement. So, decrease ang bowel sound rather than absent as in adynamic ileus and peritonitis. Okay, before deciding that bowel sounds are absent, sit down and listen where it is shown for at least 2 minutes or even longer. So high-pitch or high-pitched tinkling sound suggests intestinal fluid and air under tension in the dilated bowel. Rushes of high-pitched sounds coinciding with the abdominal cramp could indicate intestinal obstruction. Okay. So bruits. So a hepatic bruit suggests carcinoma of the liver or there is a cirrhosis. If there is arterial bruit with both systolic and diastolic component, it could suggest a partial occlusion of the aorta or large arteries. So such bruits in the epigastrium are suspicious for renal artery stenosis. Baka may stenosis lang dito or renovascular hypertension. So moving on to the sounds or to continue with the sounds in the abdomen that you can hear during your auscultation. So we have venous hum. It is actually rare. It is a soft humming noise with both the systolic and diastolic components. It indicates increase in collateral circulation between the portal systemic venous system as in to those who have hepatic cirrhosis. Another one is the friction rubs. Again, this is rare. It is a grating sounds with respiratory variation. This could indicate inflammation of the peritoneal surface of an organ like liver cancer or gonococcal perihepatitis or recent liver biopsy and etc. Okay, so after doing the inspection, the auscultation, now it's time for you to do the percussion. This helps you assess the amount and distribution of gas in the abdomen. So viscera and masses that are solid or fluid-filled and the size of the liver and the spleen. You have to percuss the 4 quadrants or all 4 quadrants of the abdomen lightly to assess the distribution of tympany and dullness. So, saan ba yung tympany and dullness? Tympany usually predominates because of gas in the gastrointestinal tract, but scattered areas of dullness from fluid and feces are also common. So, for those who have a protuberant abdomen that is tympanic throughout, it could suggest intestinal obstruction or paralytic ileus. So finally, after your inspection, auscultation, percussion, lastly, you will do the palpation of the abdomen. So you can do light palpation. So there are two kinds of doing the palpation. We have the light palpation and the deep palpation. Okay, for the light palpation, it is a gentle palpation that aids detection of abdominal tenderness, muscular resistance, and some superficial organs and muscles. This also serves to reassure and relax the patient kasi light lang. So you have to keep your hand and forearm on a horizontal plane with your fingers together and flat on the abdominal surface. And now you can start palpating the abdomen with a light, gentle, dipping motion with approximately 1 cm. As you move your hand, you have to raise it just off the skin and glide smoothly, palpating in all 4 quadrants. You can ask the patient to exhale and then palpate to aid in the relaxation of abdominal muscle. Okay, you can identify any superficial organs or muscles and any area of tenderness or increased resistance to palpation. So if there is resistance, or if resistance is present, you have to distinguish voluntary guarding from involuntary muscular spasm. So when there is voluntary guarding, this usually decreases with the techniques discussed or will be discussed in the next slides. So if there is involuntary rigidity, muscular spasm, or typically persists despite these maneuvers, could suggest peritoneal inflammation. Okay, so as mentioned in the previous slides, there are two types of palpation, the light palpation and the deep palpation. Now proceeding with the deep palpation, which is usually required to delineate the liver edge, the kidneys, and the abdominal masses. Again, using your palmar or the palmar surface of your fingers, you can press down about 5 to 8 cm or 2 to 3 inches in all 4 quadrants. Then you have to identify any masses and note for their location, size, shape, consistency, tenderness, pulsations, and any mobility with respiration or with the examining hands. Okay, so tenderness, the abdominal or tender abdomen. So we have two here, no? The abdominal wall tenderness and the visceral tenderness. So tenderness may originate in the abdominal wall. So when the patient raises the head and the shoulders, this tenderness persists, no? Whereas tenderness from the deeper lesion or protected by the tightened muscle usually decreases. So the structure shown here may be a tender to deep palpation. Okay, usually the discomfort is dull with no muscular rigidity or rebound tenderness. So reassuring your patient or explain to your patient about the procedure may be helpful para hindi siya makakaramdam ng tenderness or sobrang sakit. Okay, to continue with the tender abdomens, particularly the tenderness from disease in the chest and the pelvis. So, abdominal pain and tenderness may result from acute pleural inflammation. So, galing sa chest or sa lungs. So, when it is unilateral, it may mimic acute cholecystitis or appendicitis. When it is a rebound, tenderness and rigidity are less common. So, the chest signs are usually present. Okay, for acute salpingitis, okay, this is frequently bilateral, so the tenderness of acute salpingitis, ibig sabihin ng salpingitis is there is an inflammation of the fallopian tube, is usually a maximal just above the inguinal ligament. So rebound tenderness and rigidity may also be present. So during pelvic examination, so motion of the pelvis and uterus usually causes also this pain. Okay, so moving on to tender abdomen or tenderness of peritoneal inflammation associated with or if there is a tenderness that are associated with peritoneal inflammation, this is usually more severe than visceral tenderness. So there is a muscular rigidity and rebound tenderness that are frequently but not necessarily present. So generalized peritonitis causes exquisite tenderness throughout the abdomen. So together with board-like muscular rigidity. So these signs on palpation, especially the abdominal rigidity, could double the likelihood of peritonitis or inflammation of the peritoneum. So the local causes of peritoneal inflammation includes acute cholecystitis or acute pancreatitis. So for acute cholecystitis, the pain are usually located or originate in the right upper quadrant. So you have to check for Murphy signs. For acute pancreatitis, epigastric tenderness and rebound tenderness are usually present, but the abdominal wall may be soft. Okay, so moving on to acute appendicitis. So right lower quadrant signs are typical of acute appendicitis but may be absent during the early course of the disease. So the typical area of tenderness is located here just below the middle of the line joining the umbilicus and the anterior superior iliac spine or the McBurney point. So you have to examine other areas of the right lower quadrant as well as the right flank too when you are doing the physical examination. So for acute diverticulitis, this is a confined inflammatory process that usually in the left lower quadrant that involves the sigmoid colon. So if the sigmoid colon is redundant, there may be suprapubic or right-sided pain. So you have to look for localized peritoneal signs and a tender underlying mass. Okay, to continue with our physical examination of the abdomen, so take note that abdominal pain and tenderness, especially when associated with muscular spasm, could suggest inflammation of the parietal peritoneum or there is peritonitis. So to assess for presence of peritonitis or assessment of peritoneal inflammation, you have to check if there is localized pain. You can ask the client to cough, okay? So signs of peritonitis include actually a positive cough test or guarding, rigidity, rebound tenderness, and percussion tenderness. No, kapag ano siya. So even before the palpation, you can ask the patient to cough and determine where the cough produces pain. So pag umubo po ba, masakit, then you can palpate gently with one finger to localize the area of the pain. So the pain produced by light percussion has similar localizing value. So these maneuvers may establish the area of peritoneal inflammation. So ano ba ang guarding? Okay. So guarding is a voluntary contraction of the abdominal wall when accompanied by a grimace that may diminish when the patient is distracted. So again, this is the reference of this presentation. So before ending the first part of the physical examination of the gastrointestinal system and the renal system, let me remind you, my dear student, by reading or by sharing to you these quotes by Thomas Edison. Many of life's failures are people who did not realize how close they were to success when they gave up. So don't give up. Okay? Thank you. Thank you, everyone. May God bless us all. Okay, please watch the 3 more videos for this week. Okay, the part 2 of this presentation and 2 videos for the next topic. Thank you again, everyone.